Hello, and thank you so much for joining this webinar, Molar Hypomineralization. We have an international audience in attendance, and we'd love to know where you're from. During this introduction, you can use the chat box on the left to say hi and let us know where you're located. After that, the chat area will be dedicated to questions and comments concerning the subject matter only. So please continue to type all of your questions during the lecture in the Q&A box on the left of the screen, and they will be addressed by our experts during the interactive session. Now it's my sincere pleasure to introduce you to Dr. Erin Mahoney, who is a specialist in pediatric dentistry at the Hutt Valley Hospital in Wellington, New Zealand. Erin began researching hypomineralized first permanent molar teeth during her PhD and has continued in her postdoctoral research. She has published and lectured extensively around Australasia. Although Erin enjoys conducting clinical and lab-based research, she is primarily a clinician. Dr. Mahoney is joined today by Dr. Mike Hubbard, who is a professional fellow in oral and facial sciences at the University of Melbourne in Australia. After originally training as a dentist, Mike undertook a PhD in biochemistry and went on to pursue a biomedical research career as a biochemist. Dr. Hubbard has introduced a public awareness venture called the Chalky Teeth Campaign, authored a children's storybook about molar hypomineralization, and developed a world-first online education resource for D3s, which can be found at thed3group.org. We would like to thank Colgate for providing an educational grant which makes this lecture possible. And without any further delay, please allow me to turn it over to the experts themselves.
Thank you very much. It's great to see so many of you typing where you're from, and we welcome you from all around the world. Professor Hubbard and I are very happy today to be talking about one of our favorite topics, which is molar hypomineralization. Together, Mike and I are going to guide you through from the clinical challenges to the public health opportunities that this sometimes complicated condition presents. You heard my introduction. I'm a mother of 5, but in my clinical research, I'm a pediatric dentist. As my introduction said, I'm a researcher. A clinical researcher mainly now, although have spent a lot of time doing lab-based research. I'm a D3G representative, and at the moment I have no conflicts of interest. You're going to see throughout our presentation today that we have a lot of images, and these images have been used, that we have from our patients have been offered to use for education, and we would ask please that you don't copy any pictures that we have. We're going to go through 4 sections today, and the first section Mike's going to cover, and it's about what is molar hypomineralization and what is the problem. I'm then going to pitch in with looking at the clinical issues and the management of molar hypomineralization, and then Mike's going to walk us through what to tell people and how to learn more. You can see at the bottom of your slide we have a number of dental notations. We all come from around the world. We can see you've got some from the States and people from Australia, and we've got people from the Southern Hemisphere listening to us. And you can see that we may use different words for our teeth, but generally we're talking about ease when we're talking about primary teeth, or 2-year-old molars. And when we're talking about our first permanent molars, we use the word 6-year molars interchangeably, and also 12-year-old molars to describe our second. I'm going to pass you on to Mike now. Thank you very much.
Hi, everyone. So apologies for starting with the poll, but it's a very useful picture for us to work with from now on. And you've seen it in the advertising, so I guess you've had a chance to think about it. So is this typical dental caries? And I think for many, the answer will be an obvious yes. How could it not be? So we ask you to vote A when that comes up in a sec. For others, you'll say, well, how come this tooth over here, the contralateral molar, isn't carious? So you might vote B because it's an unusual case. And some of you may say, no, that's molar hypomineralization, and others are unsure. So if we can just have a few seconds to vote. Okay, so that's got a good range of votes there, and hopefully we can get rid of the unsure ones by the end of the talk. So no rights and wrongs. We'll address that as we go on. So you've heard in the introduction that I've spent most of my career as a biomedical scientist after training as a dentist. And more recently, my job has been to be a translational researcher and educator. So we'll explain that in a minute. And that led me to founding the D3 group, and I've got no conflicts either. So what do we mean by research translation? So simply, it's a way of converting great science, which is generally done in a lab, out to public good, so a social focus. And to do that, instead of working in the lab, we really try and get all the stakeholders together into one place. So we have the researchers, the users, such as clinicians, and the beneficiaries, such as the public. We get them all together and identify what are the key questions. Then it goes to the researchers to get the answers and cycles back to the team to address the questions. And through that approach, we end up with improved policy, practice, and products that leads to social good. In my particular case, the translational mission was based at a children's hospital and the University of Melbourne. And the idea was, could we use mad scientists such as myself to get together with doctors and dentists to do something good and new for kids? And it was really early on when we got these different sets of people together that we realized there were some real communication issues. And that led to the coining of the term D3. So by D3, we can say that's simply a contraction of DDD, which is developmental dental defect in our case. So that takes us to the D3 group, and you've heard about the website, so you might want to follow along as we go through the talk. So the D3 group we describe as a cross-sector network, and by cross-sector we mean that it's got all the stakeholders there. I just mentioned them, from academia to dental to medical to public to companies to public health and government. We're trying to translate research out and generate benefits for the public and societies. So clearly, if we're going to do that, we have to involve the public. So we have a Chalky Teeth campaign aiming to increase public awareness, and we have a very simple message telling people about enamel defects and molar hypomineralization, the links with decay, and the needs for research. So the D3 group is an informal organisation based at the University of Melbourne, run on a charitable basis, and for the past decade it's been covering Australia and New Zealand. But a year ago we opened it up to internationalisation, and we're very grateful to Colgate for their support of that through this webinar. Okay, so let's get stuck into what you came to listen about, which is molar hypomineralization. And we have a bit more of a holistic view of it. So we do look at the dental condition, but we also have two other levels that we look at, and that's what we mean by the problem. So the condition itself is clearly a developmental one, and so we call it a leading D3. The second layer that we look at is the ignorance about it. So we saw that in the poll, that lots of people don't feel familiar with that topic. So through no fault of their own. So you haven't been taught about it, but maybe also you haven't thought about it enough. So how could this molar here be so severely decayed and its counterpart not? There must be something happening. And then thirdly, the lack of research. Well, that is not surprising given the lack of awareness of the problem. But the good news is that the research situation is improving, and this is something D3 is really focused on. So let's focus on the dental condition for a minute and get a definition sorted out. So because we're trying to translate this out beyond dentistry, we need to have a very simple definition. So our definition just has two components. One is an enamel lesion called a demarcated opacity. I'll explain that one in a minute. And the other one is any molar. And then there's some optional extras. So mostly we're looking at 6-year molars, but as you've heard, there's also the primary teeth, so the D's and the E's as we call them, and also the 12-year molars can be affected. So any molar plus a demarcated opacity, that's molar hypomin. The optional extras are any other tooth in the mouth. So in this case, you can see 2 premolars are affected. And often in the 6-year molar cases, the permanent incisors and sometimes the canines are also affected. We don't dwell on those exceptions to the rule because we really want the simple message being these are the most caries affected teeth in the mouth, the molars, and they get more caries risk if they're hypermineralized. So we just stick to that simple message when we're taking it to the public. So the differential diagnosis, we need to distinguish molar hypermin from the 3 classical enamel defects. So dental fluorosis due to too much fluoride, enamel hyperplasia, which is the pits and the grooves, and then amelogenesis, the genetic forms, which affects all the teeth in both dentitions. And then we go and say, well, what's the relative impact of these different enamel defects? So we've got 4 now, and it turns out that the new kid on the block, molar hypermin, is in fact the highest impact at societal level. And this comes from its high prevalence. So we'll talk more about 1 in 6 kids being affected. And there's also a high social cost and a family cost that's high. Usually you hear about amelogenesis imperfecta being the most devastating enamel defect, and it certainly is at the family level. But the prevalence of it across society is so low that it doesn't have a big impact socially. So what we like to do is take the high impact of amelogenesis imperfecta and leverage that off the high prevalence of molar hypermin and work those 2 together. Right, the other component of the definition was demarcated opacity. So these are sharp-edged opacities as distinct from the diffuse ones that you get with fluorosis. And this is the earliest picture I can find from 1949, where it was reported these occur on all adult teeth. So clearly this is a central incisor and a very sharp demarcated border right here. Another feature is the range of colors. So this one was probably white, but often they are a creamy yellow color and sometimes more brown. And it's usually the brown ones that are most severe and can start crumbling or breaking down, as you can see in this molar, which is just erupting. So that is not tooth decay, that is not hyperplasia, that is hypermineralization breaking down as the tooth is erupting. So the next thing is we have to not confuse breakdown with hyperplasia, and there's a lot on the D3 website about that, so I'll refer you to that. The next important part of the definition is that this condition is sporadic, and by that we mean, or we can see in this case, so these are 4 6-year molars from one individual, and here's one tooth that's perfectly fine, and the other 3 are blasted to various extents. So that's very different than fluorosis and very different from the genetic defects. So that lets us think that we're not dealing with fluoride, we're not dealing with genes, we're probably dealing with some form of illness that causes it. So this means we call it an acquired condition, and the great thing about acquired conditions is that they are potentially preventable. So this takes us to thinking about research and building a case for research. So we need some solid data behind that. So our 1 in 6 kids message came from 80 prevalent studies around the world, which you can see on the map, which is on the D3 website. Some countries don't have data, but in the case of the US, there's unpublished studies that we've heard about that say the prevalence is pretty much the same as everywhere else. When we go and look at the distribution of the prevalence, we see there's quite a scatter. So the 15–16% is in the middle. So we can take from this that different people in different places will see different amounts of molar hypermin at different times. When we go to the 2-year molars, we see an average prevalence of roughly half that of the 6-year molars, and fewer data for the 12-year molars, but historical values suggest about 10%. So again, about half of what the 6-year molars are. So if we add the 6-year, 2-year and 12-year molars together, we've gone from 1 in 6 kids probably up to 1 to 5 or 1 to 4 kids. So a very common problem, but does it cause any trouble? And the answer is yes. So this is a translational view of what you're going to hear from Erin in clinical detail. So patient challenges is one level of the problem. So toothache, tooth decay and extractions. And sometimes when the front teeth are affected, there can be quite devastating cosmetic effects, and that can lead to anxiety. And all the extra dentistry involved can lead to dental fear. A number of dental difficulties that Erin will mention. And the costs, we look at those at multiple levels. The family that has to pay for a lot more dentistry, the dentist who might have failed restorations to deal with, and then the societal costs from having all this additional tooth decay. So that takes us through to the public health level. And molar hypomineralization is disruptive in three ways that we like to talk about. Firstly, the common public health message is that tooth decay is preventable. All you need to do is clean your teeth, use fluoride toothpaste, and avoid sugar. However, for many kids with severe molar hypomin, that's not enough. Their decay is essentially unpreventable unless a dentist gets in and intervenes early. Likewise, in the dental surveys, usually the DMFT index is used, decayed, missing, filled, permanent teeth, or any teeth, and no indication of the number of hypermineralized molars. So this confounds the reporting, and for example, fluoride, which doesn't work well on hypermineralized teeth, the numbers for the efficacy of fluoridation get corrupted by not counting the number of hypermineralized molars out there. Likewise, for the costing data, which is done for caries, by not separating out the hypermineralized molar data, which is costing more, then the costing data for caries is a bit confounded. The economic and social burden data for molar hypermin aren't well quantified yet, but we know enough that if molar hypermin went away, there would be huge savings in the caries area and socially through some of the anxiety things and missed schooling. So if we're going to prevent molar hypermin, we have to start thinking about the cause, and that takes us away from dentistry into medicine. So we talk about molar hypermin as being a medico-dental problem in that it has a medical origin and a dental outcome. So more about that on the D3 website. We know it's not caused by fluoride, it's not primarily caused by a gene defect, so it must be something to do with sick kids. And people have been trying to sort that out for over 40 years, and the fact that it hasn't been sorted out, unlike some other things like tetracycline staining, suggests that it's a complex issue. Quite a few suspicions around pediatric medicines, particularly antibiotics, but the studies on those are contradictory. So that leaves us with multiple diseases, medicines, fevers, and most likely some combination of these as the cause. The other thing besides the cause that's very important is to think about the timing. So remember that this is happening during development. So we're looking at the developing tooth bud several years before it erupts into the mouth. So that takes us to consider a chronological window. So if we're looking at the 6-year molar and we look at its crown, then we know that that is hardening during the first 3 years after birth. And in those first 3 years, we also see the incisors are hardening and also the tips of the canines. We also want to go further and look at the 12-year molar. So its crown is developing out to about 7 years. So that's our risk window from birth to 7 years. However, with most commonly the 6-year molars being affected, the focus is on infancy. So that takes us to a whole raft of childhood illnesses that it could be, and that's complicated by the delay between when the baby is ill and when you get to see the hypermineralized tooth. So we end up with an etiological nightmare. So that's the end of the first section, and we've looked at the condition itself and these other two levels. We've encouraged you to look not just at the tooth, but at the mouth. So it's a case level definition. We've said it's common with a major burden. There's a lot of ignorance about it, and it's potentially preventable if we get in and do the research. So I hand you over to Erin now.
Thanks, Mike. I get to pitch in now with some clinical issues with molar hypomineralization. And obviously, we're going to have to do this quite briefly because as clinicians who treat this, you know it can be complex. But a number of patients and clinicians have talked to us, me, about the different ways and problems that they have when treating these teeth. And I've listed a number of these here, and I'm going to go through each of these in more detail to help us gain further understanding of why these teeth are so different and difficult to treat than standard molars with carious lesions. So firstly, as Mike showed you, molar hypomineralization lesions can vary greatly in their size and shape, and they can often present as quite large defects. As these defects do not follow standard outlines, they can make them very difficult to treat. If you have a look at this slide, this is a slide I took of a molar hypomineralized lesion at when I was doing my PhD. And you can see molar hypomineralized lesions affect the cuspal area of a molar tooth, depending on which molar tooth we're talking about. And you can see that from this, that the hypomineralized lesion extends from the mesodentinal junction all the way to the surface. And this can help explain why some of these teeth are also very sensitive. What's interesting about these teeth is that the cervical enamel is normal. We always have a bit, and it varies depending on the size of the lesion, of normal enamel with which we can bond to. As I said, you can have a variety of clinical presentations from quite large lesions to smaller lesions, and therefore this can vary your restorative choices when you're coming to restore them. In addition, you can also see, as Mike has discussed, you can have areas that break away. And what this area that's broken away is called post-eruptive breakdown. And because of this post-eruptive breakdown, such as in this tooth, these teeth are more likely to get dental decay and be more sensitive. And how post-eruptive breakdown works is when a tooth is coming through, erupting into the mouth, the mechanical properties and physical properties of the enamel is severely affected, and I'm going to show you some of that and some research that's been done on this, and that has shown that, that this is much more porous and the mechanical properties are so different that just the occluding forces are enough for this to break away. And because this area then becomes a plaque trap, you also will find, therefore, that this tooth is more likely to develop dental decay. As I said, I did a PhD in a lab looking at these teeth, and I spent a lot of time looking at how hard these teeth were. And you can have a look at this area here. You can see the enamel in the hypomineralized lesion is severely affected. The mechanical properties are significantly reduced compared to sound enamel. Because of this, that's what makes it look more likely to break on occluding force, because this area here, this enamel, affected enamel, is more likely to flex and bend than the sound enamel. Mike suggested before and discussed before that the color of the lesion can be quite different. And if you have a look at this dark lesion here, you can see that that area has undergone post-eruptive breakdown, whereas this whiter opacity here has not. And some colleagues in Dunedin and also in Europe have looked at the amount of mineral that is in these dark lesions and found the darker lesion is less mineral and therefore is more likely to undergo post-eruptive breakdown. If you look at using scanning electron microscopy or other transmission electron microscopy, you can find that the crystals are less densely packed, the enamel crystals. The top here is a hypomineralized lesion, and the bottom is a sound enamel. And you can find that in the hypomineralized lesion, you will find that the teeth have they're more porous. They have an increased calcium and phosphate content and an increased protein content. Now, the specifics of that aren't important for this talk, but really what it's showing you is that the enamel is significantly affected. Now, a lot of these teeth, and for you and I who treat these teeth, you're going to find that these teeth are more sensitive. If you have a look at this tooth here of one of my patients, you can see that this tooth is covered in plaque. And another reason they can get dental decay is because they're sensitive for cleaning and brushing, and therefore they don't do that. And with these plaque traps, you can end up with more dental decay. And what some colleagues in the United Kingdom found is that teeth with hypomineralized defects also have increased number of neurons in them. So they're just much more sensitive teeth. And that's important when we're thinking about restoring them, because we may have to use more local anesthetic or a different local anesthetic when we coming to clean them. In addition, I'm going to talk a little bit about home cares. You may want, kids are more likely to need to use a soft toothbrush, a very soft toothbrush with warm water, because they are sensitive to cold. Lastly, as you know, when treating young children, some of these children with first permanent molars, the teeth come through, as you know, at 6. We're treating quite young children, and these children often have a significant amount of dental treatment that's needed. And a number of European colleagues have looked at this, and they have found that treating the children with enamel hypomineralization, that generally the children that have this are more anxious, and they are therefore more difficult for us as clinicians to treat. Jalvek, during her research, has looked at this and did find that the children had needed something like 27 times more treatment than children that didn't have enamel hypomineralization. And as you know, none of us want to treat a child 27 times. And also that these children are also much more anxious. What's interesting, this study, they did find that when these children are well treated by educated clinicians, that over time their dental anxiety did decrease, and then they eventually got to be able to have standard dental treatment once they were older. So that's great. Now, so those I've gone through are the clinical issues that we face. Just a very quick summary of them. As I've said, these teeth are tricky. The enamel the lesion can be very large. It's an unusual shape. They can fracture quickly and are more prone to dental decay than healthy and unaffected enamel. There's multiple treatment choices that we have, and I'm going to go briefly through them right now. But sometimes you may need to use, you call on other colleagues to help you with this. So don't be scared to talk to your local pediatric dentist, your orthodontist, or your family, or whoever else, because Mike hasn't discussed it, but I find in a number of my patients, a number of family members will also have the condition. So let's quickly talk about managing molar hypomineralization. This is, I must admit, because of my area of interest and being a specialist in the hospital, I deal a lot with this, and it makes up sometimes a lot of my day. I've taken this from one of my colleagues, Bernadette Drummond, who's a professor in Leeds, and this is our overall aims of treatment, and you can have a look at those. Those won't be very different from the ones that you have when treating any child. And one of the most important things is that we end up with a happy dental patient at the end. There are a number of, I'm only going to go through these things briefly, but there are a number of ways you can quantify and write down in your notes the effect, how big a lesion is. We also have clinical cameras, which are really useful. You can, the European Academy of Pediatric Dentistry has put out a index which you can use to record enamel hypomineralization in your patients, and are also really useful if you're going to do some epidemiological studies. But there's a couple of references here, and a book you can see that Bernadette Drummond and Nikki Kilpatrick edited that can give you some help on treatment planning, because I just can't do that in 8 minutes. So please go ahead and look in the literature. There's when we're looking at restorative choices, when we're faced with a large lesion like this, we've got intermediate restorations, we've got permanent restorations, and I'm going to go through those briefly. But you do need to consider that you may need to use sedation, relative analgesia, general anesthetic to help you be able to treat these teeth. And sometimes, as Mike has said, you may have 2 teeth affected in the mouth, or you may have all 4 that are severely affected. And you may need to think about referral for some help if you don't normally see these teeth. First of all, just talk about fissure protection. I usually use a resin fissure sealant, but when I'm thinking about putting fissure sealants on hypomineralized teeth, because the mechanical properties of hypomineralized enamel are so low, they actually have mechanical properties more similar to glass ionomer cement. In addition, glass ionomer cement doesn't require mechanical bonding. It just, as you know, is a chemical bond. So it has been suggested that fissure sealants for use in these teeth are, it may be useful if this tooth was hypermineralized to think about using a glass ionomer cement, because there has been a couple of studies that have shown that conventional fissure sealants have had poor retention, which is not surprising when you think about the enamel. The glass ionomer restorations, there has been, I've put here no studies have been conducted, but actually there has been a few studies, but not long-term studies looking at glass ionomer restorations. And most of the studies that have been done have shown the larger the lesion, the less successful glass ionomer cements are for restoring these lesions, because first permanent molars and E's or 2-year-old molars are areas that are undergoing a lot of stress from occlusion, and so they are contraindicated in large restorations. But a very small lesion, you may consider it. And you also can think about glass ionomer cement restorations if you're temporizing something prior to maybe stainless steel crown restoration. I just thought when I was young, I'd show you a slide. When I was young and had more time, I looking at etching hypomineralized enamel at different times, because I thought maybe we know that the enamel is different, but why don't we think about maybe we could just etch some more if we can get a better restoration with composite or an adhesive restoration. The hypomineralized enamel is down on the lower section of this slide and the next slide, and the sound enamel is at the top section. And you can see at no etch, it looks quite similar, but as we go across, we're getting nice, normal, standard etching patterns for our enamel. But if you have a look at even at 60 seconds and 40 seconds, we're getting lovely, normal, standard etching patterns we would like for when we're doing a composite restoration. But down the bottom, we're not getting any of that standard etching pattern, which does mean that when we're thinking about restoring, composite resin restoration does make us a bit nervous because we don't have standard enamel to bond to. A Greek colleague did some interesting research looking at composite resin restorations and found if he removed all the affected enamel, got great results. What I thought was interesting is you know, we're in the era of minimal invasiveness dentistry, and what we need to think about is that when do we take away the whole lesion, or can we leave some of our affected enamel in situ and then bond to that? Because what this author suggested, and I think it's a good advice, is that you remove the the hypomineralized lesion, as you can see down here that Peter, a colleague from Perth, has shared with me. You remove the vast majority, but then there may be little bits that you feel are a bit harder. And what Litigakis showed was that if you get a slow speed burr and on your slow speed and you just clean around the edges, you'll find that eventually your slow speed will catch, and that they believe is an area where you can then bond normally to. And that's something I think as dentists we're pretty good at feeling where our where our enamel changes. And I think that's a good hint for where you're thinking about replacing putting a composite resin restoration. So composite resins are useful in small lesions in non-load bearing areas where you have some normal enamel to bond to, and where aesthetics, obviously on the anterior teeth, you wouldn't be thinking about a glass ionomer cement. You'd want to go straight to an aesthetic. But remember that your lesions do go full thickness. They go all the way through to dentine, so you need to think about using really good local anesthetic for these sensitive teeth. But material choice is complicated, as I've said, and the size of the lesion sometimes means that we need to think about full coverage restorations. Now, luckily, as a pediatric dentist and as dentists out there, we have stainless steel crowns. They are simple, they eliminate sensitivity, they're relatively cheap, especially where I work in the public health system. They're full coverage. You can get keep your interproximal contacts correct, and they can last a really long time. We use them. They are not obviously permanent restorations because eventually the periodontal condition of a child, they get older and they need that to be changed. So we then need to look at something else and going to full crown, or as you can see in my next slide, we sometimes look at permanent cast restorations. And these are useful in the late mixed dentition or permanent dentition. And all you need to do, depending if you had an area with a lot of post-eruptive breakdown, and you can clean the margins, you can get normal enamel. You just take an impression, send it to the lab, and they make you a cast restoration. You can use composite. You could use a tooth-colored restoration. And the good thing about this is it's simple technique. It really is. You can still get bite wings. It's aesthetic. This is just a gold one I did a number of years ago. But as I said, if you use a white material, it can be much more aesthetic. Although it is expensive, it is something that you don't have to worry about replacing later. And they do have very good long-term success. Now, Mike was saying before that he says 10% of kids have their second molars are affected. I don't see that much in my clinical practice, but I have not studied that. I've only done an epidemiological study of six-year-old molars, but I've not done second-year molars. I don't see 10% of my children that I see have this. But if kids do have it in their second molars, it is much less significant than you find in first permanent molars. And so this is why we have, especially in the public health system, we have also found that we do extract a number of these teeth and allow the second molars to come into its place. So as you know, what happens is if you have a first permanent molar that's affected with molar hypomineralization, and you can see here this tooth was affected by enamel hypomineralization and also was ectopic. But regardless, if you have a tooth that's affected with molar hypomineralization and child has a class 1 occlusion and you don't need the space later for orthodontic extractions, I'm going through this again, I apologize, very briefly. There are a number of other considerations, but in some cases it works out very well. If this tooth is affected with quite severe enamel hypomineralization and the furcation of the lower second molar has begun to form, we can remove the first permanent molar and allow this tooth to come up into its space. And then if they get wisdom tooth or 8s, that tooth can move into the position of the 7s. Sometimes you do unfortunately need to use sedation or general anesthesia. And the orthodontists tell me that it does take longer if you don't get the timing right. They do have some issues, but I think we have great orthodontists that can handle that, no problems. So it can be a great way to get rid of a problem. If you have a look at one of my cases, you can see that this child here had a significant enamel hypomineralization on this tooth with post-eruptive breakdown, with dentine sensitivity, and a great risk of dental decay. So I put a stainless steel crown on in the chair, and I watched that for a couple of years. And then when the timing was right, we extracted these four first permanent molars that were all affected. And you can see here, after the second molars had come in, you can see you now have two very good arches, which that child is not going to need any orthodontic treatment. And those 7s have come through with absolutely no problems. And you have a healthy mouth with no ongoing issues. She did, of course, have some hypomineralization of her upper incisors, but we could deal with that with simple composite restorations. And that was a very good outcome for that child, and without needing any orthodontic intervention. I said I'd talk very briefly about what we do for children at home. We recommend that children use a high-dose fluoride toothpaste, at least 1450 parts per million, and or even higher, such as Nutrifluor 5000. As Mike said, there's no evidence that this works, but we know fluoride is wonderful, and we do want to make sure they don't get dental decay. So we don't see any harm in it, but there is no evidence that it's going to be any better at helping the molar hypomineralization than the hypomineralization in the tooth than anything else. Because of that, we do place Durafat and fluoride varnish on teeth as much as we can. In Australasia, this is called tooth mousse. This is a recaldent product with casein phospholipeptides in it. And in North America, which I know a number of you are from, it's called MI paste. This material anecdotally, and I have marked PhD theses that have shown me that the lab-based research is showing that it's promising and helping mineral to be deposited back into the teeth. But unfortunately, there's absolutely no clinical evidence of this, and it's only anecdotal. Some people believe it does help sensitivity, but again, that is only anecdotal. But hopefully over time, we will find some more evidence. So you can see here that there are multiple options depending on the severity of the teeth for treatment. I've had to go through it so briefly, and again, I apologize. Because it's such an interesting topic as clinicians that we want to know how to treat these teeth. We also need multidisciplinary inputs, and I recommend that you do go to the D3 website. You can see parts of it here on this slide to have a look at what at some further evidence and help with treating these teeth. So I'm going to hand you back to Mike for the final section.
Okay, thanks, Erin. So I'm going to switch gear from clinical issues to public health opportunities. And what you've heard from Erin clearly is a strong driver to, wouldn't it be great if we could prevent molar hypomineralization? So a big job there for researchers and for clinicians. I think two key things we really would like you people to be involved with is knowing what to tell people about the problem and how can you learn more yourself about it. So just a reminder about the three levels of the problem. So Erin has been talking about the bottom level, and I've lost my pointer, there it goes. And above that is the education and the need for research. So we now go and say, well, if those are the levels of the problem, how can we actually increase awareness and how can we increase research capability? You can't just grab researchers out of the air and say, fix it. And then on top of that, we've presented a raft of challenges, but how do we switch those around to becoming attractive opportunities for funding? And wouldn't it be nice if we could not just approach molar hypomineralization, but could we do good for other enamel defects as we go, particularly amelogenesis imperfecta? And because we're going to be looking at medical origins, if we're looking at interventions in infancy, can we look at other medical benefits apart from fixing their teeth? So we'll be keeping an eye here on what you as clinicians can contribute. So first and foremost, we need better communication, not just in the clinic, but outside it as well. You've heard it's a complex topic. We haven't gone into the science much, but clearly clinically it is as well. So to help the whole sector, we've made the science very approachable. We've presented it on the website in the children's section, and we've made some rather complicated biochemistry interpretable to anybody. So basically, if kids can understand it, anybody can. And then we come across to communication. So with our translational mission, we've really got to look at a translational terminology that we can go from the clinic out to the public, and most importantly, out to politicians. If we're going to get better health policy and research funding, then politicians need to be able to understand it. So when we look at existing terminologies that are used in the clinic and the literature, They all have their pros and cons, but none of them are readily translatable out beyond dentistry. So that led us to looking at a translational terminology. And you heard before about D3 at the top. And then we've introduced this series of terms, starting with what the public might use. Instead of starting with what you'd use in the clinic, we've started with the public. So we go from chalky teeth to chalky molars to molar hypomineralization, and then we can go to more complicated terms if we wish on an ad-need basis. So we like to start conversations with chalky teeth. And this is, our comfort in doing this has come about after 5 years of experimenting with it. So we introduced the Chalky Teeth campaign 5 years ago, and it's taken quite a while to iron out some of the wrinkles to keep various people happy about it. But for the public, which is what we really want to get behind this, and politicians, they can easily understand chalky teeth. They can understand that it's wrong that the enamel is discoloured and crumbles. And we can go easily from there to chalky molars, which is the subtitle of our children's storybook. So translationally, this is all about making the terminology accessible across the sector. We're using abstract terms. Chalky teeth doesn't mean anything. It's a colloquialism. It has no dental or medical meaning. It's just a catch-all. But the public can understand that chalky is abnormal. It's not a normal, hard, white, shiny tooth. And additionally, lots of people might come to you and say they were born with chalky teeth. There's a bit of a rumour about that. And that's good in a way, because we're talking about developmental dental defects in the most. In our definition or our use of chalky teeth, we embrace all the enamel defects, and we also capture early caries. So white spot lesions can look like demarcated opacities in some occasions. So why separate that out for the public? If they come to you saying they think they've got a molar hypomineralization and it turns out it's a white spot lesion because they haven't cleaned their mouth, at least they've come to see you, so that's good. So the next question is, how come there's so much ignorance about that? And I've seen some of the questions popping up on the side of the screen. How come we weren't taught this? So there's no surprises that the ignorance is there if the dentists don't know about it. So we saw in the poll at the beginning that lots of people voted that they didn't know about it. And this is the poll that Colgate ran last month. And you can see 1 in 6 people, only 1 in 6, said that they were very familiar with this problem. Twice as many weren't familiar. So interestingly, 1 in 6 kids have got the problem, 1 in 6 practitioners are very familiar with it. So how can it be that most dentists don't know about it? And one obvious reason is that often it is hidden. So if we go to this molar that we've used in our talk, it's pretty hard to see the hypermineralized enamel, but it is there just at this leading edge. And there's also some on the count on this tooth over here, this cusp. So we say it's often buried under tooth decay. So when you are going to see it is soon after the tooth has erupted or in a clean mouth. The next point is what I said before about the delayed outcome between the 5-year delay between the sick baby and when you see the tooth erupting. And thirdly, the lack of education. So how can dental educators teach about this if they don't know about it themselves? And if the research information hasn't been translated through to the education system, well, you can't blame them. But that is changing now. So the D3 group has recognised this problem, that we do need comprehensive education. So we've come up with an online education resource comprising a website and a children's storybook. And we've catered to 5 user groups from kids down to researchers. And for the kids, naturally, that's where the storybook is. We go through dental issues and molar hypermin to varying degrees. We do tooth science, oral hygiene, and some fun and games. For families, we go through the whole story from chalky teeth to molar hypomineralization and home care information. The prevalence data and economic burdens and things like that, they're under the community badge. Practitioners, mainly dental stuff, but also some stuff there for medicos. And for researchers, a variety of information, including a comprehensive bibliography. So once you've studied that website, then you're in a great position to answer the questions that crop up inside the clinic and outside it. So the easy speak, we have a section under families where we address frequently answered questions, frequently asked questions, and the sort of question that crops up and we've answered is it my fault? Lots of parents ask that. Did they do something wrong? What causes molar hypermin? So we give some simple answers about that. And perhaps most importantly is, can it be prevented? And we want a positive message there. So even though we don't know that we can prevent it now, there's certainly things that you can do in terms of maternal health and health in babies that minimize the risk. And this is particularly important. You'll frequently get asked this by a parent who's just had a child diagnosed with molar hypermin, and there may be a baby on the way. So we'd like a positive answer being given there. So nearly finished now. So we're looking at doing more research, but we also want that research to be translated out to social good, as I said at the beginning. So what we've done here in the Chalky Teeth campaign is we've taken research information that is buried in the literature and we've made it very accessible to the public and to the politicians. So 1 in 6 kids have got the problem. That's 12 million new cases a year around the world, and some of them have got a 10-fold risk of tooth decay. So that's a very simple message. So how do we switch from our data about prevalence? So we know there's high prevalence, but there's no public health policy. So how do we switch from that, the data, to needing to getting the policy that we need? So we need to get the socioeconomic data. So that's research. How do we switch from knowing that fluoride doesn't cause it to making a pro-fluoridation argument? And again, we need the DMFT surveys to include molar hypermin. And how do we go from the high caries risk that we know about to actually getting people intervening early so that these teeth don't decay and have to be extracted? So that's an all hands on deck from the dental profession, the medical profession, and parents can do this themselves. Finally, what do we need for the research? Well, Erin spoke about some of her stuff focused on better management. So clearly we need a lot of work from the dental researchers and industry to come up with better materials and diagnostics and repair and restore these teeth. Medically, we would like to prevent the problem in the first place, so that means getting into the medical cause and prevention. So in addition to dental researchers, we clearly need biomedical researchers, medicos, public health people to get in and find the cause and work out prevention. And thirdly, we need to look at worldwide variations. Is the problem manifesting the same in different countries? Do we need the same solutions in different societies? So that takes us to the need for a global research army where we take a worldwide approach to a worldwide problem and we bring together the scattered expertise that lies around the globe, and we can explore the variations that happen in the different settings. So the D3 group is developing such a research army, and moreover we're displaying what we've got as we go. So we haven't been going for long, but you can see here we've now got 150 people in 30 countries who have joined the D3 group and supporting the research mission. So we're making that very visible to research funders, and we should hope that this will help researchers get funding when they can see that there's this response across the world. And the other thing we're doing is amongst these red pins, if you click on the pin, you'll find out that there's dentists there, there's therapists, hygienists, orthodontists, pediatric specialists, there's medicos, there's company people, and there's members of the public. So it gives the impression that we've got a crowd behind this research project, rather than my whole career was an individual saying, oh, I need research funding. So we're switching it around now and having society say that we need this research funded. So switching from researcher push to public pull. And how can you people participate? So you might choose to join the D3 group and get some additional education through the members' newsletter and continuing education, and by joining you help support the cause. You can do your own thing locally, so you might use D3 resources such as these colourful cards to refer to the website and the storybook that I mentioned before. And of course, you can advocate across the sector, both to your colleagues, your patients, and out to the public. And tell them about the need for research, and if you're so inclined, you might be able to participate in it yourself. So this was the fourth goal, was how can you communicate with people and how can you learn more yourself? So it simply boils down to engaging in translational communication from the clinic right out to the public, educating yourself and then sharing that information and fostering research, either by telling people about the need or involving yourself in it. So, Erin.
Thanks, Mike. I've just got one bit from this slide. Mike would like me to talk about the clinical perspective on research translation. Well, as you know, the way we are now, evidence-based dentistry is pretty much the new norm for our profession. We can't just do what we think might work. We really have to use evidence. And research translation is defined as the process whereby knowledge is passed anywhere along the translational pathway. And you can see that the way that research has shown us clinicians why this enamel is different and why we may have to make different choices. That's, to me, where research translation has meant different choices that I've been able to make for my patients. And that's really important. I don't work in public health. I work on the patients that come into my clinic. And I think by using the research that Mike's been talking to you about and using websites such as the D3 that's being able to bring this all together so that us as clinicians can get together with researchers has been really, really useful.
Okay, and just to come back to the poll at the beginning, it doesn't matter what you voted at the beginning, but we hope that you do now recognise this as a case of molar hypomin and diagnose that by the asymmetry between these two molars. You can see the hypomin enamel here and here. It's also a clean mouth, and you can see that these primary molars haven't been affected even though they've been in the mouth for several years. So all that points to this being a case of molar hypomin. So I will wrap it up there. Oh, well, I can say it doesn't matter about whether you get it right. Well, we would argue that, yes, it does matter, because if you're going to fix this tooth or this tooth, as Erin has said, the hypomineralized enamel needs different treatment than normal enamel. So we'll just conclude that it's a big problem clinically for you people, and it's also a big problem around the world, and any big problem warrants a proportionately big response.
Thank you very much for spending time talking and listening to us talk about our favorite subject. It's been really great to hear and see all the, I can't hear you, I wish I could because it's weird talking to this screen, but I've been able to see all your questions, and we're going to have a few minutes now to go through those. We won't be able to answer them all, but I will endeavor to try and answer them all, and I will hope that Colgate can then pass those on or put on to their website. And a number of them are clinical, but before we answer those, please feel free to contact myself or Mike. You can see our emails, or you can get us, you can contact Mike through the website, and you can also see my contacts there. We really appreciate Colgate. Thank you very much for making this a priority to have one of these. And I see so many Americans I thought you might be watching the election, but I'm very glad you decided to watch the molar hypomineralization and learn about that. So we're just going to go through some questions. Mike, can you see those too? Oh, well done. The young man that's helping us has brought them up. Now, some of them, one was a number of my hope we have answered as we've gone through. One of them was one person didn't understand the difference between enamel hypoplasia and molar hypomineralization. Molar hypomineralization is an opacity, and when the tooth comes through into the mouth, the enamel defect is evident, and it's an opacity, which means it's a defined defect. But when a hypoplastic tooth, which is significantly less prevalent, way less prevalent, comes through, the tooth has actually come through without enamel being present. For example, you might see a hypoplastic, there's types of amelogenesis perfecta which are hypoplastic types. add to that, Mike?
I'm happy with that. There's a lot of information on the website to help people.
There's one, and these questions are great. You've obviously been listening, so thank you very much. It says, what do the radiographs show? And what's really interesting as a clinician, I take OPGs. I'm presuming that everyone knows what those x-rays of the whole developing dentition. And we will find the x-rays underestimate the extent of molar hypomineralization. And so it is sometimes difficult using just a radiograph to diagnose it. You do need to have a look at the patient clinically rather than just looking at it on an x-ray. And that's why it's sometimes hard when you send an x-ray off to an orthodontic colleague and you say, oh, these are really hypomineralized, I think I'm going to take them out. And they might think you're a bit crazy because it just doesn't look like that. So that's why we send slides as well, like pictures as well. A lot of questions here are about silver diamine fluoride, which is an excellent question. In New Zealand, we're not able to use it yet, which is crazy. It's just a regulatory thing. It will be coming. So I myself have had no experience with silver diamine fluoride on hypomineralized teeth. As you know, silver diamine fluoride is there to reduce dental decay and to remineralize lesions. Hypomineralized and you usually use on primary teeth because they are teeth that eventually will fall out. And often we use on children who are pre-cooperative, so can't have standard restorations done. Now, if you were on the primary molars, I don't see why it would hurt if you have access to it, because you would be able to reduce the chance of dental decay. But from a point of view of in permanent teeth, the problem is that if you get post-eruptive breakdown where the silver diamine fluoride would go, you still have a problem of that this is a permanent tooth. And so eventually you probably need to think about restoring it at some time, but possibly it may be useful for a pre-cooperative child, you know, a child who's not cooperative at 6, but maybe cooperative at 8. It may help with sensitivity, but again, as I say, I have had no experience because in New Zealand, we're not allowed to use it. Do you have any thoughts, Mike?
I've heard from a number of people around the world who have used it, and they talk about it glowingly, apart from the obvious side effects of the discoloration. So I think we're looking forward to some studies coming out.
And maybe as soon as our government lets us use it, I'm sure we'll be using it that way. Have one question here about what anesthesia technique and anesthetic do I use? I use articaine on hypersensitive first permanent molars, and I use that on primary molars as well. I find that works significantly better than lignocaine. And I apologize if it's not called that where you're from. Please email me and I will figure out what yours is called in your country. And I find that works a lot better than lignocaine for these really hypersensitive ones, although I use lignocaine standardly on other children. And it says, can you remineralize the hypomineralized tissue with fluoride varnish? And there's no evidence that we can. The enamel is so disrupted that I believe that you, and the PhD theses that I've looked at, you really need to soak this tissue in a high calcium and phosphate and fluoride materials such as MI paste or tooth mousse for quite a long time, and the oral environment so far is not conducive to that. Sometimes people have made little suck down appliances and blocked out the hypermineralized and then put MI paste in and then put it in the mouth with MI paste in that specific area and have found that may work. But again, all that is anecdotal. There's another here. You guys are great questions. Would you use the Hall technique for stainless steel crown placement? Absolutely. If you can in the first permanent molars, and in the E's, absolutely. In the second primary molars, absolutely, you could use the Hall technique. Yes, because it's cuspal. I think it lends itself so much better to the Hall technique in primary molars than it does in proximal lesions, because you can see it, and it also, hopefully you can get that Hall crown on before it becomes carious. No, there's other ones here, but I think that generally that's about it. There's individual people that I can reply to. Mike, here's one for you. But if it is somewhat preventable and research has been going for over 40 years, how can we prevent it?
Well, I think that's a curly question. I think it likely is preventable if we can find the causes behind it. So this is a circular argument. The causes that have been investigated are logical ones, but far from comprehensive. So I think once we start putting more of a medical perspective on it, and more of as we learn more about the pathology and can anticipate what the pathogenesis is and focus on how come 1 out of 4 molars can get affected, it takes us away from thinking about just systemic disruptions such as too much fluoride. So I think maybe we haven't been quite on the thinking has needed to evolve a little bit. So I think we should do the research, and we need to switch from just focusing on the tooth to the ill babies, and start making some hypotheses around what could be causing one tooth and not the other 3, for example, to be affected. And I saw a question there following up on, are genes involved? So clearly they are involved if you go to epigenetics and single nucleotide polymorphisms and things like that. So yes, genes must be involved because they affect how we respond to illness. So when we say it's not primarily genetic, we're making the distinction from amelogenesis imperfecta, which is a classical monogenic disease. So we're not comfortable that it's a monogenic disease, but that's not to say that there'll be genetic contributions. And Erin's study in Wellington looked at some different racial groups and didn't show a big difference between those racial groups. And I think there's going to be some twin studies information published shortly. And again, that will possibly show that there's not a strong influence from genes, but you can't dismiss them. How about that? While I've got the mic, I might just add a little bit to having seeded the idea that fluoride doesn't work. Those comments I was making were referring to the moderate and severe cases. I certainly go along with what a lot of practitioners do, and in the mild cases where the enamel surface is still intact and shiny even, so the small white opacities, well, clearly you would use remineralization products as you do for a white spot lesion. So I just make that distinction. It's the severe cases that are going to break down and decay and need to be extracted. Those are the ones that we're talking about at public health level that need to be accounted for.
Thanks, Mike. I think we've got one more question that a number of people have asked about resin infiltrate or icon products. Those are showing promise. They have been used by a number of clinicians, and I think that that's an area to look out for. Whether it will change the mechanical properties so that you don't get post-eruptive breakdown, I don't believe it will, but it might a little bit, but it may help with sensitivity, and it also may help with caries, just like it does in unaffected teeth. Well, I hope we have stimulated your interest and you will go away and learn more about this condition. It affects 3 of my 5 children, so and myself. I have it too, so it's something that's close to my heart and close to Mike's heart. So we really appreciate you spending time with us today. We hope you have a lovely evening, and we will and please contact us if you have any other questions. Thank you so much.
Bye.
Thank you so much, Dr. Mahoney and Dr. Hubbard, for your experience and your expertise with us. The webinar recording will be posted online in the next 48 hours. You'll receive an email notification with the link to the recording. Please note that only by attending a live webinar will you earn an interactive CE credit. Further questions may be submitted directly on the website on the course page under the Ask the Expert tab, and our experts will be sure to get back to you as soon as possible. The CE quiz is now available online on the course page, and completing it will allow you to earn your ADA CERP and AGD PACE CE credits. We would also like to thank you for your interest and participation. Please keep an eye out for our growing schedule of online courses. Thanks again, and all the best.